We're here at the 22nd CROI. We're here with Jay Kostman with CFAR, Center for AIDS Research, and University of Pennsylvania, and we appreciate your taking the time to present a little bit of information on the hepatitis co-infection issues and background, and kind of give us the big picture. But we're not going to talk too much about what's going on here at the CROI. We have other programs that are going to do that. This is more about the background of the hepatitis and get people prepared for those presentations, I guess, if you will.
Sounds like a good idea.
Yeah.
Thank you, Fred. It's a pleasure to be here. I think this is really a seminal moment in the history of hepatitis C, and particularly hepatitis C HIV co-infection. And where that comes from is the fact that those of us who've been doing this for a while have seen the bad times, have seen when we weren't treating people who were co-infected for a lot of different reasons. And then when we did start to treat them with interferon-based regimens, their initial responses were not nearly as good as in people who didn't have HIV infection. And so we struggled with that. We struggled with the idea of how we could modify their HIV regimen so that they could tolerate hepatitis C treatment. And it's really over the past 2 years since the advent of more specific or so-called direct-acting agents for hepatitis C treatment that have really improved the response rates to hepatitis C treatment, both in mono-infected and particularly co-infected individuals. And now with the blooming of the interferon-free era and all oral drug regimens, it's just amazing to see treatment responses, the ability to treat people who are co-infected and have the same responses as if they were mono-infected with hepatitis C.
I know that every disease or pathogen has certain dynamics that make it either difficult or more or less difficult to create a anti-whatever. But have you ever seen anything move so quickly in such a large, massive way and have so many drugs out there on the horizon?
It is really amazing, and it's amazing both in quality and quantity. And over the past really short period of time, couple years, to have not just new drugs, but new drugs that are so effective and, importantly, so well tolerated, so that people who really couldn't be even considered for treatment can now be. I don't think there's been anything like it in medicine, at least in my career over the past 30 years.
I don't know how the companies manage to. They always talk about setting, the bar has been set, and then they have to jump that hurdle or whatever it is. But it seems like they're all jumping at the same time, because obviously they want to have the best drug that is going to be able to do the most with the least amount of side effect, which is the big thing in this particular issue, and then also the ability to clear this infection.
Right.
A large percentage of the time.
Right, and I think that particularly for people who are co-infected and they're used to hearing, okay, their HIV is a, quote, chronic manageable condition, unquote, now. And yes, we're all looking more forward to a cure in the future for HIV, but it's not here right now. And so when you go through with someone who is co-infected and you talk about what is going to result from treatment, and you sit down with them and you say, well, after 12 or 24 weeks of therapy, your virus is going to be gone and you're cured.
They're not used to that concept.
They're definitely not used to that. And it's a good concept to be able to tell people, but still, it takes some time. And I clearly have had people who we have cured and who don't believe it. And they'll come back and we'll retest them and prove to them that their virus is gone. So it really is, it's something that has changed dramatically the view on a disease.
Can you talk to the different versions of the virus, because they're a little bit different?
Sure. So there are several, but 4 main genotypes or strains of hepatitis C that infect people in the United States. Really only 3, but there are others worldwide. And although typically the genotype 1, which is by far the most common in the United States, was traditionally the most difficult to treat, so that you had people who you told them they had the most common strain, and then you have to tell them, well, our treatments are not nearly as effective. And that is not true anymore. Most of the newer agents that have both been developed and gone to market are specifically targeted against genotype 1. And so now we can say that those treatment response rates are just as good as any other strain. And actually, it's more genotype 3, which is less common, making up 10 to 15% of the hepatitis C infected people in the United States, that is becoming the more difficult one to treat because it seems to be associated with certain changes in the liver, particularly with increased fat in the liver, that make it a little bit more difficult to cure. Still way better than we were in the past, but it's really something that we didn't recognize even 18 months ago, and something where still newer drugs need to come to market to help us achieve the same kind of cure rates as we are with the genotype 1s.
Can you talk a little bit about the different types of drugs that are out there that are, I mean, I know that we're not selling drugs here, but some of them are out now, others are going to be out
right
near future.
Right, certainly within the next year or so, yeah, there will be another wave. The traditional drugs that we used before the past 3 years or so were interferon and ribavirin, and we actually still don't know for sure how either one of those drugs works specifically against hepatitis C. Interferon boosts the immune response and allows the body to clear hepatitis C in some individuals, and ribavirin seems to work in conjunction with that. However, the next generation of drugs that came along were really specifically developed to target different parts of the hepatitis C virus, including the hepatitis C protease and then 2 other enzymes of the hepatitis C virus called NS5A and NS5B, which both act to aid viral replication. And so the drugs that are now available target each of those steps along the virus's life cycle, and the regimens that seem to be working best actually target multiple of those steps along the way, sounding very familiar to what we know about with HIV infection going back. And as combination antiretroviral therapy became more effective, it was because we were targeting different sites along the virus life cycle. So that is really what has prompted the dramatic developments in hepatitis C treatment.
Can you talk a little bit about how when a person begins treatment, they can learn, or the doctor can learn how likely it is that they're going to clear the virus?
So, yeah, that's a very important point. There are some predictors that we know both prior to treatment and then with the beginning of treatment that can help us. And it's one of the things that's really important as we push forward as a community of treaters and consumers, that we have to push, because we know, for instance, that people respond better to treatment if they do not have advanced liver disease, particularly cirrhosis. And so staging someone's liver disease, and in particular determining whether or not they have cirrhosis, is really important prior to treatment for a number of different reasons. One is it does give you an idea of how likely someone is to respond to therapy, but probably even more important is it influences their clinical course, so that if someone has progressed to cirrhosis, there are certain things that we need to monitor to make sure that they don't develop clinical complications. So we need to make sure and screen them for hepatitis C, for hepatocellular carcinoma, for esophageal varices, for the development of ascites or fluid in the abdomen. So those things are very important. In addition to that, their particular genotype or strain is also important. And with some of the newer drugs, they work better against genotype, what's called subtype 1B compared to subtype 1A. So knowing that beforehand. And then thirdly, the height of the viral load, or how much virus there is in the blood, because that is sometimes used as a marker for whether or not we can use abbreviated courses of therapy with certain drugs. So in other words, 8 versus 12 weeks of therapy.
So that's a good segue, because I was going to ask you about how, I know that they're charging so much per pill, and I think that some of that is based upon the course of the disease, the drugs that they're going to need to take to become cleared, rather than, or cured, rather than than the number of pills per se. I mean, and they may be different for some people.
Definitely, they may be different. So, for instance, in someone who's been previously treated with interferon and ribavirin and not responded, and particularly if they have cirrhosis, the courses of treatment are going to be longer, on the order of still as long as 24 weeks. Whereas someone who's never been treated, who has minimal scarring or fibrosis in the liver and a low viral load, less than 6 million, can get 8 weeks of the combination of sofosbuvir and ledipasvir or Harvoni and have as good a chance at cure as if they received a longer course of therapy or different combinations of drugs. And so knowing that, so that we can be at least cost conscious as we're using these medicines, I think what we have to be advocates for, however, is that if people are coming into care, regardless of their stage of fibrosis, if they're ready to be treated and cured, then we need to do everything we can to be able to try to get them therapy, because that's the point in time when they're ready to be cured.
And that was going to be my next question, is how do we advocate? How do we advocate as physicians, as patients, as general advocates, as community advocates?
And I think it's really important to do that. And I think it's just, and again, this is where the co-infected population, I think, can be leaders in this, because we as providers, as well as the consumers, have made a career, so to speak, of being advocates. It's why many people have had access to drugs all along the way, as you well know. And so we need to teach the people who are dealing with hepatitis C how to do that. And it's really being relentless. It's using contacts with political people to say, listen, this is an important disease. We don't want to ration medicines here. We want to be able to treat people that we can. You need to work with the pharmaceutical companies so that we can figure out how to do that in a cost-conscious way. And you know, one of the things about hepatitis C is there is no Ryan White system for hepatitis C. So you know, there isn't a payer of last resort here, and that limits the access to treatment to many people, and that's something that I think we have to really keep our guard up on.
Is there any, we said we were going to talk about co-infection, but is there, in mono-infection, is this also the same story, except for the fact it's less rigorous or onerous?
Yeah, in mono, the beauty of our current treatments are we no longer have to differentiate co-infection from mono-infection. We shouldn't be using HIV co-infection as a criteria to either consider holding treatment or giving treatment. If anything, those that are co-infected should be prioritized, because we know from many years of work that they have a more rapid progression to advanced liver disease, and that progression can occur even if their HIV is completely suppressed. So someone with HIV and hepatitis C co-infection really should be prioritized for treatment in order to prevent the progression of their liver disease. But people who are mono-infected shouldn't be ignored in that setting either.
There is no reason why anyone should not be treated as soon as possible for their own good, because we don't have this issue of the horrible treatment, the bad result. We also have this issue of the need because of treatment as prevention.
Yeah, so, agreed. And there is really a public health imperative here that, that we do treat people to minimize transmission. Now, that just like with HIV treatment as prevention, that's part of a menu of messages, I think, that needs to get out there. But realizing, for instance, that in an injecting drug-using population, treating their hepatitis C can definitely decrease transmission because of the potential transmission with not just sharing needles, but sharing other kinds of drug appliances, cookers, cotton, etc. So part of that message is treatment as prevention, and part of it is needle exchange programs and other harm reduction messages that we can get out there.
Because we are concerned about the patient's due diligence in taking the medication. That is a critical piece of it too. So
it is definitely
adherence.
critical, and it's a very understudied area. Again, those of us who come at this from an HIV standpoint, we say, what do you mean you don't know about adherence? But there really has been very limited data that's looked at adherence, and even something as simple as what's the minimum adherence required in order to achieve a cure. Can you miss one dose a week? We don't know that.
This is really something that I think we need to research, and we were going to begin to talk about future work, and this might be one of those pieces that's really seriously needing to be looked at.
Without a doubt, and that again, it's another collaborative effort. At the Martin Delaney Symposium yesterday, a message about collaboration with the community, and this is an area where that really needs to be emphasized, because working with people, how can we ensure that people are going to take their meds? Maybe it is a modified directly observed therapy approach for some populations, but I think and what we hear a lot is, well, you know, if it's a transient population, it's going to be hard to treat them. I don't think that's a good answer. I think what that should be is we need to figure out how to get the drugs to them, whether it's going into the methadone programs or going to the needle exchange programs, and figuring out how we can integrate our care with the other services that they're getting.
You know, another section, I'm not nearly as familiar about the drugs and hepatitis per se than HIV, but there's a lot of work being done on injectable, durable treatments. Is this something that they're considering in hepatitis?
So,
you know, whatever, you have one shot and it's an injection and it's deposited in there and it leaches out.
So it would be nice. I think that's a ways away with hepatitis C. The drugs, although their half-lives have increased over time, so that, for instance, when the first oral agents came out, we were giving them 3 times a day, and now usually we can get away with once-a-day drugs, but the development of parenteral formulations is still not on the horizon.
It'd be a great way to go, especially for people that are having problems with their drugs. And
the focus instead has been on shortening regimens with oral agents, so pushing the envelope in certain populations to say, okay, you only need 6 weeks or 4 weeks. And so those studies are ongoing, and it does look like it is, as we talked earlier, it's very dependent on certain patient characteristics in terms of who can be treated for a shorter period of time.
Are there any differentiations between a male and female, or black, white, Hispanic?
So another interesting point, because traditionally, in the interferon era, we knew that blacks did not respond as well as Caucasians to interferon-based therapy. That does not seem to be the case at all with the oral agents. And although the clinical trials that were done, as is common, typically underrepresented both blacks, Latinos, as well as women, in the real-world studies that have come out or that are being presented both here and at other places, it looks like blacks respond just as well as Caucasians, and women respond just as well as men. One of the things that is somewhat predictive is that people who weigh more and are bigger, if anything, don't respond as well, and that's probably a combination of not enough drug and fat in the liver, because fat in the liver is
equally represented both visually and internally.
Yes, definitely.
So those two things are important. So does that mean that maybe they need to do some evaluation and check blood levels and so forth?
So in certain instances, I think the cure rates are so high with these drugs, over 90%, often over 95%, we tend to forget about that there are still 5 5 to 10% of people who don't respond. And so not forgetting those people and figuring out why it is, for some of the reasons that you've just brought up, adherence, weight, whatever it is going to be important, because if we don't get rid of that 10%, we're just going to create a population, a smaller population, but one with potentially more recalcitrant virus to treat, which will be difficult.
Well, Jay, you've really handled the subject well today. I think it's been very helpful to our audience, and hopefully they will have learned something from this, and they will be able to go and watch our other videos on the science that happens at the conference here. It's been really important to have this hepatitis integrated into the CROI, and it's because it's so interactive with, like you said, it's very problematic for the co-infection. Not that the mono-infection isn't important to be addressed, but the co-infection is very important.
Right. I completely agree with you, and I think it is good that we're seeing more emphasis placed on it.
Thanks again.
My pleasure. Thank you.